Hey everyone, welcome to another episode of Finance Simplified, the official podcast for StreetFins. We're here to break down the world of finance for you to understand from a relatable perspective with discussions with experts. This is episode 18, and today I have Alex Patel with me again. How have you been since our last episode?
Hey Rohan, I've been pretty busy with school, but otherwise everything's good.
Yeah, same thing here as well. So just like the last episode, we want to update you with how we're building a community around this podcast and the mission of simplifying finance for everyone. We mentioned in the last episode that we have a club on Clubhouse, also called Finance Simplified. Alex, can you update us on where that's at?
We were absolutely blown away with the response of those who joined our club on Clubhouse, also called Finance Simplified. We now have close to 4,000 members. We've got a lot planned for the club, and if you have any ideas, definitely let us know by emailing us at fspodcast@streetfins.com or filling out the feedback form in the description. Just search up Finance on Clubhouse, and it'll be among the first results.
For sure. And we also have some more exciting news. We were recently featured as the 10th best podcast about finance to listen to in 2021 by FeedSpot. We're truly thankful to be featured and to have their support. You can check that ranking out in the description.
We're also going to be posting a lot more updates on social media in regard to the podcast and StreetFins. So head over to Twitter and Instagram and follow us at StreetFins. Links are in the description.
All right, so that was it for our updates. So, Alex, this is part 2 of our conversation with USC Professor of Health Policy and Economics, Dana Goldman, on the topic of simplifying healthcare economics. What did we talk about in part 1?
So in part 1, we got to learn the basics of healthcare economics, the different entities in the healthcare system and the roles they play, and the most important laws and regulations in healthcare.
We'll be getting more into the pricing of different products and services in healthcare, alternative healthcare systems, COVID-19's impact on healthcare economics, Dana's thoughts on the future of healthcare economics, and much more in this part. But before we continue, we just want to remind you that if you are learning from our episodes and want to keep supporting what we're doing, we'd be eternally grateful if you gave us a 5-star rating and review on Apple Podcast. Additionally, we'd love to know what feedback you have for us. So fill out the feedback form in the description to let us know how we're doing and what you would like to see from us going forward. Also, stay tuned till the very end of our episode because we'll be teasing out April's guest. The first person to send us an email with the correct guess will get a shout out. Now, let's continue simplifying healthcare economics. From the minds of the students at StreetFins, this is Finance Simplified, the podcast that simplifies the seemingly complex and confusing world of money. I'm your host, Rohan Gupta.
Something kind of related to pricing of drugs, and particular prescription drugs, is this idea of inelasticity. And who really determines, in the US especially, who determines drug prices? Is the consumer, is the patient, or is the insurance company taking a price? How does this inelasticity factor work in healthcare markets?
Okay, so the first thing is that this comes back, how does the price determine? You have a very powerful manufacturer, sometimes there are substitutes, close substitutes. Sometimes they're the only thing on the market. And so they have varying market power, but this is typical monopolistic competition. But then you also have a very powerful insurer. They know they have to provide something to their consumers, but they're representing large numbers of buyers. So, when United Health negotiates with Pfizer over the price of a cancer drug, that's larger than when Switzerland negotiates with Pfizer. They probably have more members, or maybe it's about the same size. So these are behemoths negotiating prices. Now, you asked about the elasticity. If demand is very inelastic, what that means is people will take, if they have this illness, they're going to take it regardless of price, or they're going to need it. That gives a lot more power to the manufacturer. If demand is very elastic, that is, you charge a little more and fewer people will take it, well, then the manufacturer may have less market power. So this notion, how you bargain between these two behemoths depends a lot on the nature of demand and how elastic it is. And by the way, that elasticity, as you know from studying economics, depends on the availability of close substitutes. So if Pfizer were the only vaccine in town, that has a different dynamic than if there are lots of different vaccines that potentially the insurer could trade off against.
Definitely. So we've covered the pricing of drugs, and then there's the other side, which is the price of insurance premiums. So could you go over a little bit on how insurance premiums are determined? And actually, like a decade ago, the Affordable Care Act was passed and that made some changes to how insurance premiums can be determined. Could you go over that a little bit?
Sure. So in the insurance business, they've always made their margin by insuring a book of business, getting enough people that the law of large numbers works, and you'll converge to the average. And then they charge a certain, what we call the load on top of average spending. So, for example, if I tell you that the average employee at, let's say, USC, we have, 40,000 employees. On average, I expect they're going to spend $8,000. Then I could charge a 5% load on top of that, $8,400, make some money, and the law of large numbers will work. So that's an employer who might self-insure. If there's uncertainty over that $8,000 number, by the way, or you only have a few employees, or, for example, you have some really risky treatments that could throw you off by millions. For example, they need some rare genetic treatment that costs tens of millions of dollars, then these things, you can see how everything gets screwed up. But the insurance industry traditionally has been, here's the actuarial value of this book, and then I'm going to charge a load on top of that, maybe 15%, and we'll administer. Now, that was the world where people just submitted claims. It's gotten much more complicated because now insurers like Kaiser are actually providing the care. They're not just administering claims. They can set the prices like we talked about. Remember, expenditures are P times Q. If the insurance company can also determine P and it can limit your access to Q, then it has a lot more levers that it can control over this dynamic of premiums. But the ACA, to try to limit competition, what we'd like to make sure is that insurance market is competitive, just like any other insurance market. So what they said is, here's the actuarial value, and we're going to limit how much profit you make off that. Now, it turns out that is wrong for a variety of reasons. One, there is a lot of competition among insurers. And two, insurers have the potential, if they're big and powerful, to also lower the price they pay providers. So they can lower premiums as well. So again, think about P times Q. If I have an 80 million person book of insured, I can go to the healthcare providers, the hospitals, and say, I want a 25% discount or I'm taking my 80 million people elsewhere. Well, that right there is a haircut of 25% off P times Q. The question is, do I keep that and give it back to my shareholders, or is it going to go back to people in the form of premiums? And so, again, you've got these large insurers with buying power, again, monopsonistic power. And whether that is a good thing or a bad thing is actually an empirical question that has gotten a lot of attention in health economics.
Yeah, and that's a perfect segue to my next question. So you mentioned that these large insurance behemoths, a lot of them private, most of them private, they have huge bargaining power and they have control of millions of customers and patients. And so in the last election cycle, an issue that came up quite frequently was universal healthcare and sort of like a single payer system in the United States that kind of removes the privatized insurance companies and those interests and just have the government providing health insurance for citizens. Do you have any thoughts on the feasibility of this? Is the U.S. system positioned for such a change?
Yeah. So let me say something about single payer. One of the virtues I said about it before was everyone's in the same contract for life. So you get rid of adverse selection. You get rid of this short-term versus long-term. So it has a lot of virtues. And you also get rid of some of the administrative costs that are associated. But what you also get is you lose the regimented behavior that private insurers bring to the market. So you get a lot of waste because, as Milton Friedman would say, when people are spending other people's money on other people's utility, you don't pay a lot of attention. And what's going on here is what you see in programs like Medicare and Medicaid is an enormous amount of variation in care. And no one has a financial profit incentive to weed out a lot of that waste. In fact, if you're a politician, for example, and you go after, let's say, the home health agencies, then they might lobby against you and say you're a terrible person, and so it may politically hurt you. On the other hand, if you're a large insurer and you see a lot of waste in the home health system, you go in and you fix it because your shareholders are going to be really upset with you if you don't. So the waste in the public system or in a single payer system is one about just overusing resources, especially resources. We see this like with closing a hospital. Suppose there's an underperforming hospital in a neighborhood. Hospitals become a political football all the time, and it's very difficult for people to close a hospital. Whereas in the private sector, if they're not making money off their hospital, they will close it in a for-profit setting. So you are trading off some of the virtues of the single-payer system against some of the efficiency of a private market. And that is a difficult choice to make. What I will say is, if you're a fan of single-payer or you're a fan of markets, both of them can be done much better in the United States than they are today. So there's a lot of room for improvement, regardless of your ideological view of this.
Yeah, and the politicians as well, in addition to universal healthcare, I mean, the big thing that they're also talking about is how COVID is going to be changing healthcare economics. So I'm curious to know, what were some of the trends in healthcare economics or just the industry generally before the pandemic, and what trend is continuing from the previous, or is there a change? And when I'm thinking of asking that question, I'm thinking of what has social distancing done? What is sort of this postponing of hospital visits or your traditional regular doctor visits? What is all that going to do to the industry and the field of healthcare economics going forward?
It's transformative in the way that COVID has changed our lives in so many ways. I'll just give you a few examples. The first is, and this was going on in the supply chain generally, which is people don't like waste, overcapacity in the system. Too many empty hospital beds we used to think was a really bad thing because hospitals are expensive. They've got huge fixed costs. Suddenly COVID comes along and we realize, oh my goodness, we need ICU beds. Like, the worst thing is people will die if we don't have enough ICU beds. So this question of what is the optimal capacity of the system, especially if you're worried about public health, is going to completely change as a result of this. Another example is digital health. We knew this was a trend beforehand, but it was kind of happening in fits and starts. But a lot of people enjoy interacting with doctors via telehealth. It also democratizes, in some ways, access to some of the specialists because you can get it in rural areas. On the other hand, people with technology can take advantage of it. So it may exacerbate health disparities. It changes the dynamics of how we interact with the healthcare system. And all of this is going to play out in ways that aren't very clear. And I think more generally, you talked about the delay. People have stopped getting some of their care. Are we going to see an explosion in late stage cancer diagnoses because people didn't get screened? Or are we going to find out that it gets back to this waste, that actually mortality from these other things, people did okay, even though they were denied a little bit of care? And maybe not seeing your doctor as regularly isn't as bad as we thought relative to the cost. So someone's got to come in and look at the data and say, probably some cancers will be missed and lives will be compromised, but we also save some money. And we need to do the calculus and see, does it help? Now, you don't want to say, you know what, we need a good pandemic to save money in healthcare. That is not the view. But it does suggest that we'll be able to use this to figure out where we've suffered from overuse due to market distortions and where there's been underuse.
Right. And I think another thing, with all these delays, right now, healthcare spending for the regular consumer is not nearly as high as like the regular doctor visits, but you might just see sort of like an uptick once everyone's vaccinated. There might be a huge like uptick just because everyone's kind of rushing back and trying to see, do I have cancer or I need to get the surgery that they've been postponing for more than a year.
Yeah, no, there'll be some latent demand that's there, and it'll definitely move. And it might be hard to get an appointment to get your elective surgery, 3 months from now. The evidence does show that people do time their care around, for example, annual insurance. So if you know that you've already met your deductible, you might move something from January back to December. So it goes both ways.
And another question I had is, today's December 14th when we're recording this. This episode will be out next year sometime, early next year. But, with the vaccines currently being rolled out, I was hoping you could explain a bit more about just the economics of, Pfizer and Moderna and all these different companies that have had their successful vaccines. What are the economics of this vaccine rollout? And maybe what's your prediction for this?
Sure. It turns out vaccines are not a profitable part of anyone's business. And if you look at their revenues from, say, cancer drugs and chronic treatments, they swamp this. And in fact, the irony is if the vaccine is successful, it'll wipe out any demand. So if we get rid of COVID, then your treatment wipes out. So Wall Street does not like a vaccine. And you'll see that the approval of the vaccine did not bump Pfizer's share price in any dramatic way because that's not what they do. The companies that are engaged in this understand that they're dedicated to innovation to help humanity, and they saw that there was a role for them to play in this thing. And I think a lot of this was just done out of goodwill and using resources that were paid for by all these prices that these premia that we pay above marginal costs that allow us to maintain this innovation ecosystem. So I really think it's interesting about vaccines, but it's not about the money here. It really is about the science and the urge to do good. And they'll make some money enough to cover their marginal costs. But I suspect this race was about bragging rights and be able to go into the room when you negotiate your cancer drug and have some goodwill because you came up with a vaccine.
Yeah, that's a great point. And I think it's just really remarkable how we've seen since the start of this pandemic, hundreds of companies rushing in to do vaccine trials. And we already had, I think, 8 companies in phase 3 trials, which is just a great feat. So I think it's something we can all be very happy with. Now, my question's sort of going back to your personal experience with healthcare economics. And I think you're famous for the Netflix model, and I think we've seen a lot of comparisons between software and sort of the healthcare market. And so the idea of licensing drugs and all these different ideas, and just in general, how have you enjoyed working in academia, and how has that given you sort of the ability to come up with these different theories and come up with these really driving philosophies that you might be seeing employed in the healthcare markets?
Yeah, it's a great question. And in academia, we get to think at a very high level. We're not in the day-to-day, okay, I have this drug, I've got to figure out how to offer it to patients, and we've got to get it through Medicare and the private payers. And you can see how there's an engine there, and you've got to fire that engine, and you keep going down the same road. In academics, we can say, is there another way to do this? And do we really need to go down this road at all? Is there another route to get where we want to go? And I've really appreciated the idea that I can think at a broad level about, could we do these things better? Now, what often happens, and this notion, that's the good notion of the ivory tower, but sometimes that is given a very negative connotation because it's very hard to see how you get from the road you're on to this new road. And so the challenge for people like myself is you've got to come down out of the ivory tower and talk to the people on the ground about how you can actually get there. And actually we are with this Netflix model, which, I've been talking about for 10 years. And it comes back to this, like you said, this subscription model, because treatments and drugs have more in common with, like I said, Netflix than they do other healthcare providers. There's a lot of regulations that interfere, but we're starting to get rid of those. And we're exploring these subscription models in a lot of areas of healthcare. And so that's a positive development in my view.
All right. We're on to our final two questions. So the first of the final two is, knowing what you know now and just the fact that you're so experienced with this field of healthcare economics, where do you see the future of healthcare going? And we just talked about telehealth and how certain people were liking that trend. What role do you see technology having, and just anything in general about where the future of healthcare economics is going?
I think you've hit on one thing, which is we've talked about innovation. We talked about it on the pharmaceutical side, and obviously COVID has highlighted that. There's obviously technology generally and how that all the innovation, and we like the innovation, especially when it's small companies. The other concern, though, is the enormous market power from consolidation that has occurred. Large insurers, large healthcare systems that monopolize an entire region, the buying up of small players. And so one of the tensions here will be, how do we create a market environment that is efficient, but also doesn't crush the small players? And how do we prevent this from being just a bunch of local monopolists who figure out how to extract rents from the rest of us? We're spending 20% of our GDP on this. And if you can figure out just a small way to get a margin, you can make a lot of money, but that's at the expense of other things we could be spending money on that we like. I'd like to go to the movies again. And so, I think the challenge will be both this market structure, market power, and then this innovation ecosystem. And there'll be a lot to keep us busy for the next decade.
Right. And so, this podcast, it's called Finance Simplified. It's meant for students and young people to kind of get an intro to the world of finance through the perspective of both Alex and I, who are young people. So knowing what lessons you know now about economics and the industry in general, what lessons do you generally teach your students or even your kids about healthcare economics or economics more generally?
Well, another great question. I think the lesson here is really about the importance of regulation and how regulation distorts behavior, sometimes for the better and sometimes for the worse. And we know that this market can't operate without being regulated for all the reasons that basic economics doesn't apply. But the trick is to think about the benefits and the costs of regulation and to take a long-term view. With COVID vaccine, it seems obvious, we should just give it away for free. That is so obvious. But the long-term consequence is who's going to develop the next one if we expropriated the technology. And so you really need to be trading off short-term benefit and long-term harm and thinking about intelligent ways to make sure that the market works for us and not against us.
Well, with that, I just want to say thanks so much for being on the podcast. It was a real pleasure to have you. Healthcare economics is a topic that Alex and I did a lot of studying up on beforehand, so we're really glad we had you on to help simplify this for us.
And thanks for having me. It was nice to interact with both of you. Take care.
Hey everyone, that was the end of part 2 of our 2-part interview with Dana Goldman on simplifying healthcare economics. We hope you enjoyed and learned more about healthcare economics from him. The entire conversation was amazing. Alex, what were some of the key takeaways from the second part?
I think one key takeaway is how monopolized the pricing of drugs is. You have these huge, powerful entities, the healthcare insurance companies, the biotech and pharma companies, and the government, that are all negotiating the prices of these drugs. And it does depend on elasticity. If there isn't any competing drug or treatment for an illness, then the manufacturer of the cure to that illness has a lot of power and would represent more price inelasticity. If there are a lot of competing drugs for a particular illness, then the insurance company may have more power as they can choose to buy cheaper drugs and treatments on behalf of those that they insure. This would represent more price elasticity.
Exactly. And when you look at insurance, the premiums are determined in a similar way. You measure the risk of paying for healthcare services for someone who suffers a health issue, and then you charge a little bit more, the loading, so that you cover your losses if more costs arise. But with the Affordable Care Act, and this goes back to the role of the government, the premiums that insurance companies can collect are limited, which introduces a new dynamic to the healthcare insurance market. Additionally, as Dana mentioned, when you look at different healthcare systems, namely universal healthcare, also known as single payer, or market-based healthcare, you come to realize that both could be improved upon.
Yeah, and another thing I found quite interesting was how healthcare economics approaches this COVID-19 pandemic situation, especially the production and rollout of the vaccine. The field also revealed to us why these biotech companies really do vaccine production and what's in it for them. And to finish, the final takeaway is about where healthcare economics is headed in the future. It will continue to tackle issues and problems surrounding COVID-19, the monopolization of the market, and innovations in technology and their impact on healthcare.
Agreed. Well, Alex, that wraps up our part 2 conversation and takeaways. And now it's time for us to tease the next episode's guest. Remember, the first person who sends an email to us at fspodcast@streetfins.com with the correct guest will get a shout out in the next episode. So, here are the 2 hints for our next guest. Number 1, he's the former chief risk manager at AQR. And number 2, he's a professor of finance and the author of several books about finance. The next episode will be out on April 1st, so we'll talk to you all then. Hey guys, I want to thank you so much for listening to this episode of the podcast. It truly means the world to us. If you like this episode and others, let us know by subscribing and giving us 5 stars on Apple Podcasts and following us on Spotify. Share us with your friends and check us out on Instagram and Twitter, both at StreetFins. You can also follow me on Twitter at RohanInvest. If you'd like to get in touch with us, please email fspodcast@streetfins.com. Thanks once again to Dr. Dana Goldman for his insights today. I hope you understand healthcare economics in a more simplified way. Once again, we're really happy that you're taking the initiative to learn finance and to better your future. If you haven't already, we highly encourage you to check out streetfins.com for articles, videos, and other content. Join the StreetFins community and tell your friends about us so that they can learn about finance too. We'll talk to you next time on Finance Simplified.